Hello, I'm Dr. Carolyn Nam, Associate Editor of Circulation, and I am so delighted to be reporting from Rome this time at the European Society of Cardiology. We are discussing the 10-year follow-up paper on STICH that includes an age analysis that's being featured as a hotline session of Clinical Trials Update. So I'm here with the distinguished guest, the first author, Dr. Mark Petrie from University of Glasgow, the corresponding author, Dr. Valezquez from Duke University, and the associate editor who managed this paper, Dr. Nancy Sweitzer from University of Arizona. Welcome.
Thank you, Carolyn. Thank you.
Right, let's get straight into this. So, Eric, remind us what it first showed and why there's a need to look at the effect of age.
Thank you, Carolyn. Thanks to Circulation and to both of you for really helping us work through this paper. We're very excited that we're being able to feature this work in Circulation. So the STICH trial, as a reminder, the surgical treatment of ischemic heart failure trial has been a 15-year effort, actually, that started with its first patient enrolled in 2002, enrollment ending in 2007, and at the ACC, it was a simultaneous publication in New England Journal, we published the 10-year results of the STICH trial comparing medical therapy versus CABG plus medical therapy in patients with ischemic cardiomyopathy defined as an EF less than 35%, coronary disease amenable to CABG, with over 90% having class 2 or greater heart failure symptoms. What we showed in our 10-year results was that CABG, when added to guidelines-directed medical therapy, led to a substantial reduction in all-cause mortality, cardiovascular mortality, as well as all-cause plus cardiovascular hospitalization in those patients who were randomized to the CABG arm. This translated to about a 18 months extension in survival for the CABG patients over that time period, a 16% relative risk reduction in mortality, and nearly a 10% absolute risk reduction in all-cause mortality, with the number needed to treat of approximately 14. So with those findings, the next question that we wanted to address rapidly was whether there was an impact by age. And this is what we're here to talk about, mostly because everyone recognizes that age is also something we can't control. As we age, our risk for everything increases. And clearly, heart failure, which is the field that we work in clinically, patients who are older in heart failure have more risks and worse clinical outcomes than patients who are younger. Whether there would be a benefit that would persist in terms of the treatment in younger as well as older patients is really the subject of this analysis.
Boy, that's great. So maybe, Mark, you could tell us the highlights of the results, but give us an idea, first of all, of the age range that we're talking about, what you looked at, and then this is definitely going to be an issue if we're talking about age, the relative risks versus the absolute risks of the different types of outcomes?
Sure. So the patients in the STICH trial were of similar age to a normal heart failure trial. So the mean age was around 61. What we did to look at the patients we had in the trial, we looked in quartiles first of all. So the lowest quartile was age less than 54, and the highest quartile age more than 67. So we had a fair spread of age. We didn't have many patients who were very elderly or very old. So 5% were above the age 75 and 1% above the age of 80.
Okay.
So when we looked at the patients, we saw a similar spectrum to a usual heart failure trial. The older patients had more comorbidities, not surprisingly, and they had they basically died more often as they got older, as we see in every other trial. So when we started looking at the results, the treatment effects of CABG, obviously we were very eager to know if the benefits, which Eric's talked about already, were seen across all age groups. I think clinicians, when they look at patients for bypass surgery, have anxieties around sending older people for bypass surgery. So we were thrilled, is probably the word to say, that we saw benefit across all the age ranges. So the point estimates first in terms of all-cause mortality were all less than 1. So we saw consistent benefit, or certainly across the board benefit in terms of all-cause mortality. What we did see, though, and we were very interested about, were the younger patients got more benefit in terms of all-cause mortality, and really quite strikingly more. So again, the risk reduction was over 40% for those. So we saw the upper age groups having benefits with hazard ratios or risk reductions of round about the teens, as in the major overall trial results, but the younger patients got particular benefit. We then looked at cardiovascular mortality, and we saw a slightly different pattern, that we saw the benefit was actually quite similar across all age groups. So the older patients were getting the similar reduction in cardiovascular mortality as the younger patients. So those are the main take-home findings.
Okay, so by extrapolation then, the younger patients, a greater proportion of their deaths were probably cardiovascular, or there's a bit more of a competing risk, so to speak, from non-cardiovascular deaths in the elderly. Is that kind of the idea?
So Carolyn, that's exactly right. So because the cardiovascular mortality reduction was similar across all age groups, because old people, as we know, die more commonly of non-cardiovascular events, and we saw that clearly in the trial, the benefits in terms of all-cause mortality weren't quite as much in the older as the younger populations. But just to emphasize, the cardiovascular reduction was consistent across all age groups.
With bypass compared to medical, yes.
Exactly.
I think an important aspect to remember, and I think STICH reminds us, is that even in the oldest population, and although we did these analyses continuously, we described this in quartiles for the purpose of the paper. We have to remember that in heart failure patients like these who have coronary disease, cardiovascular death is the most common cause of death, regardless of you're young or old. What happens is that as we get older, there is an increasing rate of non-cardiovascular deaths. So it's not surprising to us that the findings we found, which is that as the risk of non-cardiovascular deaths increase in the aging, the impact on all-cause mortality is mitigated slightly, while the effect on cardiovascular mortality remains consistent, because it's still by far the most common cause. I think more than double the cause even in the oldest group. So
That's a great point. Now I've got to ask something though. What did you do about crossovers? Because this is a 10-year thing. The original results of STICH came out 5 years. You'd expect that there's quite a bit of crossover, or no?
I'll just comment on the effect of crossovers in STICH in general, and then we can focus on the age analyses. What's really interesting is that in STICH, approximately over the time period, there was approximately an 18% rate of crossovers. What that led is that they actually led to, by the intention to treat analysis, a decrease in the effect size that we're able to show by intention to treat. But when you look at crossovers, so the medical therapy patients who were randomized to medical therapy but received CABG at some point, and the patients who were randomized to CABG but never did receive CABG, it actually, when you look at as treated analyses, by the treatment they received, not when necessarily they were randomized, the effect of CABG actually increases. And the relative risk reduction is about 25% in that group. So then, thankfully, the effect of crossover in the different age quartiles wasn't different. That we had the same, the same effect. So we were very interested in knowing to make sure that there was no increase in crossover rates in the older versus the younger, and we did not find that based on that. I started the discussion, maybe you can complete it.
I think you've hit the nail on the head, Eric, that there weren't many crossovers, but if there were crossovers, if the crossover towards CABG, the benefits seemed to be greater, and that was seen across all age groups. There was no differential between the older patients and the younger patients.
Then I just want to know what's your take-home message, and then I'd really like to hear from Nancy what the take-home message we wanted to convey in our journal.
So I think for me, the take-home message goes back to the fundamental approach to assessing a heart failure patient in a clinic. And over the years, there's been a tendency for patients not to investigate and look for coronary heart disease. People tend to focus on medical therapy and device therapy, but the coronary arteries have been the poor cousin. So I think we would urge people to think about revascularization by surgery, coronary artery bypass grafting as a treatment for heart failure. So certainly in my practice, we look for coronary artery disease more, and then we think about the patient and weigh up the pros and cons. And certainly this analysis was done to give us granularity from a perspective of the older person and the young person, and the relative benefits. So basically it's steered me towards looking for coronary artery disease. And then also you can inform the patient in the clinic and have discussions with the surgeons about the benefits in terms of the all-cause mortality across age group and the cardiovascular mortality as well.
Consistent. That's brilliant. Nancy, speak on behalf of our journal.
So at Circulation, we were very excited to get this paper because as heart failure clinicians, we all struggle with this issue in older patients in particular. When we look and find coronary disease, these tend to be patients with higher surgical risks. Our surgical colleagues are often hesitant to operate. The benefits are perhaps less apparent, and this data is very helpful to show us that in a patient in whom the heart disease is the primary morbidity, surgical revascularization has a clear benefit for these patients. Now, I do think it's important to remember, though, that the STICH population is a selected population and probably a little bit healthier than the average patient we see in clinic. And so, as Mark rightly pointed out, the discussions with surgical colleagues, I think, can now occur with a greater level of data substantiation and understanding of the true benefits. And then competing risks and morbidities in these patients need to be considered with the reality that surgical revascularization benefits the patients. We're really excited to have worked with this fantastic group of authors to get this paper to a point where I think it's really going to have a clinical impact. And that's what we're trying to do, as you know, Carolyn, on the editorial board at Circ now, is publish really high-quality science that's going to impact the practice of clinicians seeing patients on a daily basis.
Thanks so much for that, Nancy. And actually, I was going to congratulate you, gentlemen. In your paper, you so humbly said that these are exploratory, I think, and I was actually thinking we're never going to have a better trial than this, and it's something I am personally taking to be clinically applicable in my heart failure patients, so congratulations. I'm going to switch tracks a little bit. We're actually going to do a simultaneous publication in Circulation from the European Society of Cardiology, and I think that's really neat for our journal, Circulation. I want to ask each of you, as author perspective and as the associate editor who made this happen, what do you think of these simultaneous publications? Were there challenges? What was it like? And what was your experience like?
So I have to confess that usually when we submit papers for review, there's a mixture of trepidation, fear, generally quite negative thoughts. So we submitted it, and I've got to say it was the most interactive, positive experience I've had so far. So it was quite clear the journal were interested in the data. I wanted to publish it in a way that informed the clinical community. So they certainly worked with us to make sure the message was honed and as accurate as possible to reflect the results. So we were really thrilled. It was a breakneck pace is also probably the best way to describe it. So we worked day and night actually, but there was phone calls and emails happening with very rapid sequence and lots of responsiveness, and I could almost describe it as fun.
Kudos to you, Nancy. And from your point of view, was it fun?
It actually was fun. I think, we've all had the experience of, on both sides, being an editor and being an author, of getting a paper, getting reviews, sending it back, getting the revision, it's not quite what you want, reviewing it again, sending it back, getting it back, it's not quite what you want, and then you feel obligated to publish a paper that's not really what you want. What we've decided to do is a much more interactive process to say, we're going to work with you to make this the paper we want to publish. We hope that as authors, that's the paper you want to have written. We're doing this on a regular basis at Circulation, but this was, at hyperspeed, I would say.
How long?
So we knew the paper was going to come in. We had been in contact with Eric, and I identified reviewers before we even received the manuscript, and I had identified reviewers who would commit to a 72-hour turnaround. In fact, our reviewers did it in less than 24 hours. Then I looked at it, added to it, called Eric, and we talked it over. And then we sent it back with the formal replies. I think Mark then worked 24/7 to get it back to us very quickly. And then I worked with one of the senior associate editors. At that point, we didn't involve the reviewers. And we basically track changed the paper to make the changes we really thought were necessary at that point. It wasn't a lot, but I think they were critical changes at that point. Mark and Eric were kind enough to accept those changes, and the paper was on track for simultaneous publication. And I do want to mention that we have simultaneous publication of 5 different presentations here at ESC in circulation online, which is certainly a record for circulation, and we're really proud of that.
If I could add, first of all, I want to thank the journal. Really a remarkable, wonderful experience. I've been very fortunate in my career to be in a position to submit simultaneous publications previously, and this was a wonderful, I think it was a 14-day turnaround. It was remarkable. And the responses from the reviewers were outstanding, even if they were given a very short time, and I think the paper definitely improved. Just a general comment about simultaneous publications as you bring it up, and I think it's an area of controversy.
Exactly.
I think from my perspective, as a person who does clinical trials, as well as sees a lot of patients, there's an ethical mandate, I think, that exists to, once you have information that you're putting out there, to be in a position, if we think it's clinically impactful, and we feel that the data is mature, to get that into people's hands, all of it, as soon as possible. And there's certainly a difference between what I can speak to in 8 to 10 minutes on stage with slides that will get distributed anyway across the world, and what, with Nancy's help, we are able to put into a journal like Circulation and really explain the story and give it a full vetting. I just feel like from the ethical perspective, being able to push forward with a simultaneous publication is in the best interest of our patients. And it's so exciting to see Circulation now doing this at the European Society, which is a remarkable achievement for this new editorial board. So thank you again.